So we are absolutely delighted to welcome you to our East of England opening event for the Psychological Professions Week. If we could have the next slide, please, that's perfect. So we're thinking about the impact of psychological interventions on the self-management of diabetes and respiratory conditions. And we're going to consider this within the context of common mental health problems, so anxiety disorders and depression. I'm Maggie Rosario. I'm chair of the East of England Psychological Professions Network. I'm also a clinical lead in NHS Talking Therapies. And if we could go back to the previous slide, that's perfect. I'm joined today by members of our Psychological Professions in Physical Health community of practice. Most of our presenters here today are long-term physical health conditions leads for their services or trainers on our regional long-term conditions course. You can see the organisations that they represent here on the slide. And this is a really unique event, the first time that our services have come together across the region to present on our work, to recognise the importance of uniting both physical and mental health, to share with you some of our outcomes, to emphasise the benefits of collaboration and of referrals for the good of those who use our services and the wider health system around them. So if we could have the next slide, please. Just thinking about meeting practicalities today, we're recording the meeting, so if you could please have your microphone muted and your camera switched off. This is a safe space that's confidential and respectful. It's non-judgmental and non-pressurised. We hope that it will be a supportive space, and we really encourage you to ask us questions and put comments. And if you could use the chat, please, rather than raising your hand, that would be fantastic. Next slide, please. OK, so this is what we're going to be doing today. We're going to be setting the context, so thinking about our services, thinking about the national and the regional picture for mental and physical health. We're going to provide a rationale for integrating mental and physical health care. We're going to talk about the impact of psychological interventions on the self-management of diabetes and also of respiratory conditions. And there'll be a chance to ask and address questions and comments. Please use the chat, as I said. And then we're going to gather your feedback at the end so that we can see what difference it's made to you as well. We could have the next slide, please. So just to provide some context for you, we're talking today about the NHS Talking Therapies services for anxiety and depression. And these services were formerly known as IAPT services. We're part of a national programme delivering evidence-based psychological therapies to people with common mental health problems. So that's anxiety disorders and depression. Since our services started, they've been expanded to include people with long-term physical health conditions and medically unexplained symptoms, as well as anxiety and depression. All of our services have key features in common. So we collect routine outcome measures every single session so that evaluation can be made of progress in treatment. We also gather patient feedback early on in treatment, so in terms of patient experience, and also at the end. We also use a stepped care treatment model so that the intervention, the treatment offered, matches the level of clinical need. Next slide, please. So you can see here the stepped care model. Within our services, we offer 2 levels or steps of treatment. Most people enter at step 2 for low intensity treatment based on cognitive behavioural principles, such as guided self-help, behavioural activation, or computerised cognitive behaviour therapy. Other people are assessed as needing high intensity step 3 treatment. This is what you'd probably think of as more traditional therapy and is primarily but not exclusively cognitive behavioural therapy. And you'll hear a bit more about that as we go on through the meeting today. Both our psychological wellbeing practitioners and our high intensity therapists have additional long-term conditions training on top of their core training. If we could have the next slide, please. So the services that are presenting today, we've pooled our data across the region for the time period between October 2022 and September 2023. And you can see that in our services, we've had 89,329 referrals, of which about a third were for people with long-term physical health conditions. Now, our services differ slightly in how we record whether or not people have a physical health condition, depending on whether or not it's the main thing that's brought them for treatment. So this number, 29,382, is likely to be an underestimate. But anyway, you can see that 11% of those people had diabetes and 15% had respiratory conditions. In terms of our treatment outcomes, we have good rates of reliable improvement on measures of anxiety and on depression and health-related symptoms or impact. And our outcomes are in line with national expectations for the region. Okay, if we could have the next slide, please. So we're now going to show a short video that was kindly provided by Sandra Harold, who is our East of England clinical advisor for NHS Talking Therapies for anxiety and depression. Unfortunately for us, she's on holiday, but as a committed advocate for the integration of physical and mental health, she really did want to contribute today. So we have a video from Sandra that we're now going to show.
Good afternoon, everybody. I've been asked to spend a few minutes talking about why the mind-body link is so important and looking at the link between physical and mental health and the difference that it makes to patients. I've called it the mind and the body working together to maximise health outcomes. The mind and the body work together in our daily lives to help us navigate our way around the world and explain our experiences to us. This mostly takes the form of subconscious automatic thoughts about how our body is feeling and performing in real time, based on what is happening to us and how we see it. These come to the forefront very quickly when something happens to the body that causes it to feel pain or distress. The changing nature of these thoughts can have an effect not only on the physical body, but on how we see ourselves coping in the world going forward. This is especially true of people with lifelong, long-term health conditions. By joining the physical and mental health care offered together in treatment plans, it is possible to recognise and support people with long-term conditions or life-limiting illnesses who may be struggling to overcome negative and anxious thoughts about their condition, thus finding a healthier way to manage that condition. The good news is that the majority of people adapt well to medical interventions. However, the significant percentage who do not take up a disproportionate amount of clinic time, as well as having a more miserable life than they need to. It is important that these people are identified as early as possible and offered treatment. By including a mental health component in physical health care, it is possible to change this and greatly improve the quality of life for this cohort of patients. Finally, research shows that if patients are able to manage their thoughts and develop a problem-solving attitude to their condition, they develop a more positive narrative about themselves and the world around them, and the immediate and longer-term outcomes are much better for them than if they hadn't done this. During this part of the PPN week, you will be hearing about the Talking Therapies long-term condition work, which has been pioneering in this area of work with physical health colleagues. Thank you very much for your time.
Sorry, I'm talking, I'm on mute. We're going to bring the slides back up and I'm going to hand over to our colleague Julia from the University of East Anglia. Julia, do go ahead.
Thanks, Maggie. So at the University of East Anglia, which is in Norwich, we are supporting NHS Talking Therapies staff with some top-up training specifically about long-term health conditions. Next slide, please. So I'm just going to talk a little bit more briefly about setting the context and providing the rationale for why it's important to integrate mental and physical healthcare. So the NHS long-term plan does lay out that NHS Talking Therapies services will expand the service to support people with long-term physical health conditions. Next slide, please. So one of the reasons this is so important is the numbers of people living with both a mental health condition and physical health conditions here. So you can see that illustrated here. And although we understand that not everybody with a long-term health condition will have a mental health comorbidity, they are at higher risk of that than the general population. So we're talking about 1 in 10 people. So that's not 1 in 10 of your patients, but it's 1 in 10 people in England off the street. So it might include yourselves, your family, your friends. So this is the numbers we're talking about, and this helps the case when thinking about the importance of this work. Next slide, thank you. So in our region, in the east of England, actually these stats tell us, or what we're heading towards in the future, is that we're looking actually or understanding that around 22%, which is approximately actually 1 in 5 people, when we're looking at adults over 65, will have a long-term health condition and a mental health condition, and the chances are that these are connected, because living with a long-term health condition can bring about restrictions, uncertainty, fear, loss, various losses, change, and mental health problems can affect many things, but people may be avoidant, and that might be due to low motivation, or it might be due to fear. But essentially it can mean may mean that somebody isn't able to attend to their physical health and self-manage their physical health as much as they would like. So we all need to self-manage our mental and our physical health, and we can hopefully understand why depression, depressed mood and anxiety disorders are such a potential significant barrier to self-management. And we understand that if our physical health is better, that's going to improve our mental health. So it might be because there are less physical restrictions, less frustration, less troubled by the impact. And of course, our mental health as well, it can impact on our physical health. If we're mentally better or even thriving, we're more likely to attend and look after ourselves physically. Okay. So this review just highlights physical activity as an effective treatment which can be incorporated by mental health and physical health staff alike. Physical activity, physical movement, we understand more and more now improves our physical health, and it also improves our mental health, and can therefore be incorporated into rehab and or psychological therapy goals. So we just want to make this point really around incorporating this into self-management, and this opportunity that we've got for us all working in mental or physical health to do that. Next slide, please. We go. Oh, they've disappeared. Hopefully you had a bit more chance to digest the slide about physical activity and movement there in the British Journal of Sports Medicine.
I'm just wondering whether Fumi's still with us. Are you still with us, Fumi?
I am. Can you see the slides yet?
Yes, we can see them. We just can't see that they've moved on.
Okay.
Super.
Thank you. If we can just pop back one. Thank you. So this is taken from the document Prevention is Better Than the Cure, but what it does highlight is actually it's not going to be unreasonable for us to assume that the increased rates of people living with long-term physical health conditions mean that we will see increased numbers of people who are going to need psychological support. So it's not just across our region in the east, but all over the country. We want to raise awareness of the impact which psychological support can have for those with physical health problems. And you can see on this slide here the real direct impact of that. And lastly, we understand that our physical health colleagues are really doing this work as well. But as a group, and the psychological professions, we'd like to make a bigger contribution and really maximise our impact in this area. So we were recognised in the long-term workforce plan as doing that, and we hope that this can only kind of grow. Okay, thank you. So my colleagues in the region are now going to go on to give some examples of really the work that is happening on the ground in trying to do just that.
Thank you, Julia. So my name is Becky Clodfelter and I'm a psychologist and long-term conditions lead from North East Essex, the Therapy for You service. As Julia has said, but also in terms of Sandra's feedback, it's so important that we look at this integration of physical and psychological well-being, and this presentation, which is very much a collaboration from all of these services across the region, will give some examples, but specifically in relation to diabetes. So if we could move on to the next slide, please. So these diagrams beautifully show in terms of that integration. So 3 in 5 people who are living with diabetes, I think this is quite surprising, quite shocking, will experience emotional or mental health problems as a result of their condition. And of course, if we just think about, say, insulin injections or managing food intake, carb counting, that kind of thing, it starts to make sense. 3 in 10 people living with diabetes said they definitely felt in control of their diabetes. Well, again, rather surprising. Thinking about people who are accessing types of support, so perhaps looking at self-help materials, there's maybe an underrepresentation here at times, but I think the people who are coming into our Talking Therapies services presenting with diabetes quite often may not even recognise the impact that managing their condition may have on, say, stress or depression. So the diagram on the right very much shows this downward spiral. So sometimes people managing conditions, perhaps if they're starting to become quite unwell, might have habits that get out of control, like becoming less active, or in terms of diet. And then in terms of becoming able to manage their condition, it becomes really difficult. That, of course, then increases stress, and we get into this downward spiral. So if I could pass you over onto the next slide and onto my colleague.
Hello, thank you. My name is Edward Farrow. I'm one of the long-term condition leads at a service called Total Wellbeing Luton. So just thinking about what psychological therapies might be able to offer. So NHS Talking Therapies provide recommended psychological interventions. So this can be for standalone mental health problems or in the context of a long-term physical health condition. And the most widely used psychological therapy within primary care or talking therapies is cognitive behavioral therapy, something we call CBT. CBT is based on the principle that emotional distress is linked to your thought patterns and also your behaviours. And it's been shown to be an effective treatment for people with diabetes and to be able to help improve health outcomes. So subsequently, if we can improve health outcomes, we can reduce the strain on physical healthcare services too. Next slide, please. So in terms of the treatment options available, we offer CBT, as I mentioned, so that can be individual or group-based. We also offer self-help workbooks, so that can be done by patients at a pace that suits them in their own time. And we also offer specific long-term health condition groups, so that might include diabetes, but We often have groups specific to the problem we're working with that will be dependent on a service. We offer something called Silver Cloud, which is a computerized CBT program that people can work with through at their own pace, with or without the support of a psychological wellbeing practitioner. And we also offer other recommended therapies too, if CBT has been tried before, one of which is counselling for depression. Other examples might include interpersonal therapy, which is more kind of geared towards relationships, couples counselling for depression, and something called EMDR therapy. But usually at your assessment, that would be discussed, and the treatment path you would be discussed there too. Next slide, please. So in terms of some examples of problems that psychological therapy can help with, one of the more common ones is things like difficulty with motivation and self-care, and also managing worry and uncertainty about the future. So that might be about kind of everyday worries, but it might also be in the context of the long-term health conditions such as diabetes. We know what a big adjustment it can be to adjust the diagnosis, so we can also help with that. And we'll talk a little bit more on this in a moment, but things like phobias and overcoming fears, perhaps something like a needle phobia is getting in the way of managing diabetes, so we can work with that too. Perhaps low mood and rumination, so overthinking about present circumstances or the past, and also things like panic attacks and anxiety. So it's not an exhaustive list, but it is some of the common examples that we might work with psychological therapy in talking services. Next slide, please. So in terms of what you might want to look out for in your own clinics or as a patient, difficulties with motivation to make lifestyle changes or take medications perhaps to help manage diabetes. It might also be the case that maybe the patient or yourself has been managing your diabetes quite well until recently, but as of late you begin to struggle with managing your diabetes care. You might notice somebody perhaps big changes in emotions, so perhaps become very tearful, very, very anxious, or they might be kind of sharing negative mindsets towards their diabetes management or the future prognosis of their diabetes. So for example, sharing thoughts like I'm useless or I can't cope. Next slide, please. Further examples might be, again, kind of difficulties adjusting to diagnosis, things like phobia of testing blood sugars, administering insulin, attending blood tests, etc., which we know, of course, can have a really big impact on diabetes management. Perhaps displaying excessive worry about their health or the future, and also having difficulties with falling asleep or staying asleep. So in psychological therapy, what we try and do is we try and develop case formulations. And this is an example maybe of a vicious cycle or a negative cycle of a patient we might see. So the situation perhaps is a high blood glucose reading. And starting from the top of the diagram where it says thoughts, this person might be having thoughts like I'm useless, or I'll never be able to get a control of my diabetes. There's no point in bothering. So working around to the left-hand side, you've got the kind of emotional response, feeling quite sad, depressed, and perhaps miserable, and feeling very lethargic and unmotivated. And perhaps for this person, their coping behaviour at the moment is to comfort eat, which of course in the long term has more consequences for their diabetes management. Next slide, please. So in psychological therapy, what we might try and do is you might try and work with the thinking patterns and also the behaviors, so using specific techniques and strategies. After working through this case formulation with a patient, we might see the thoughts change to things like, it's only one reading. I wonder what caused that. Is there anything I can do now or change in the future to stop it happening again? Of course, as an emotional consequence, the person will probably feel more positive and happier and have increased motivation to manage their diabetes. And as a result of that, the behaviors might change from comfort eating to things like reviewing what I had for breakfast, making a plan for my next meal, and perhaps starting some physical activity to help with bringing blood sugars down. So it's just an example, really, of one kind of formulation, how it might work in treatment. Next slide, please. So I'll just hand you over now to my colleague to continue.
Hello, my name is Tanya Marks, and I'm the Long-Term Conditions Deputy Clinical Lead for Hertfordshire Talking Therapies. And I'm here today to talk about a case we've had in our service, who we have called, so we've now called this case Nancy, which of course it's not her real name. So this was a woman in her mid-30s working in education, and she came to therapy because she was feeling unable to look after her condition, so type 1 diabetes, which was affecting her mental health. And she had been diagnosed at the end of 2021. Next slide, please. So in the assessment, we noticed that there was a previous history of depression. So it means that this was not the first time that she was struggling with depression. There was also family history of type 1 diabetes. So we noticed that her father had type 1, and actually that shaped her view and expectations about what it meant to live with type 1 diabetes. And she also reported some risks, so historic self-harm during her teenage years, and she was also presenting with thoughts of suicide at the moment. In terms of goals for therapy, she said that she would like to manage diabetes. She wanted to feel more in control. She wanted to be more like herself again and to do things that she enjoyed, which she had stopped doing. Next slide, please. But there were some challenges during treatment. The first one was high levels of frustration with everyone involved in her care. That was with the GP, with other healthcare professionals, and ourselves from Talking Therapies. And this came from a place of fear. True fear, where she felt that she wasn't being supported, that she wasn't being offered the help that she needed to manage such a tricky condition that it is type 1 diabetes. And she really believed that no one was listening, and why doesn't anyone care? Why I'm not given more support, more intense support, more frequent support, because this can be such a life-threatening condition. And also, it was noticeable that there was a lack of confidence in the professionals involved in her care, which of course impacted her ability to engage. So we had to really build very gradually. It took some time to build that rapport with the patient, to build a good therapeutic relationship, which enabled her to feel safe to then open up to the difficulties she was experiencing. And one of the things we've noticed is that she was not taking the medication as prescribed. She wasn't injecting as much as she needed in terms of insulin. So there had to be some contact between ourselves and our healthcare professionals, and of course, putting safety plans in place to support her to make sure that she was safe. And she also reported additional difficulties such as recurrent panic attacks, which made it harder for her to manage everything that was going on. Next slide, please. So in terms of the treatment itself, so she received low-intensity CBT, which were 6 sessions, 30 minutes each, over the telephone. And the main technique was behavioral activation. This technique is really helpful to build motivation and to target low mood, so improves low mood. And it's a very collaborative technique, so it's about gradually rebuilding our lives, focusing on the things that we need to do, that we would like to do, and gives a sense of meaning and purpose to our lives. And it's about following the plan, not the mood. So even when we feel quite low and we don't feel like doing anything, we still do it, as that's what we committed to do. And that seems to have really beneficial for her. Next slide, please. So here we can see her scores and how they change since she came to us. So at the beginning, when she came to us, she was presenting with moderately severe levels of low mood, and depression, which actually remained quite high throughout therapy. And at the end, we can see that dip, and where she significantly improved. She wasn't necessarily in recovery, so we offered her actually two additional sessions, which she actually refused. She said that actually I've taken from treatment what I wanted, and she felt much better in herself. So she was happy to be discharged, but still quite a significant improvement symptom-wise. Next slide, please. So here we have the anxiety score. So similar to the low mood, very high levels of anxiety throughout treatment, which just reflected how difficult this was for her. And at the end, a significant improvement as well. Next slide. So this one, it's more in terms of her ability to function and her perceived ability to function. So it's the work and social adjustment scale. So from the scores throughout, actually, since the beginning, from the end, there was a significant impact in her life. Living with type 1 diabetes was much harder than she expected to be, which actually was an additional difficulty to adjusting to living with it and implement the changes that she needed to. But again, towards the end, there was that improvement again. So next slide. So in terms of outcome and discharge, so even though just looking at the graphs, it didn't really look that she recovered, she took so much out of treatment. This was someone when she came to us, she was signed off work. And after 6 sessions, she was back at work, working part-time. This was someone who went from being in bed all day, feeling unable to cope and function in her everyday life, to actually engaging again in activities that she had stopped doing completely. So she was back to spin classes and kayaking, which was quite impressive within 6 sessions. And it was really hard for her to mourn, to grieve the loss of her of her life before diabetes, and actually coming to terms with the fact that there had been a bigger adjustment and such a big change to her life that she wasn't expecting. And she found that really hard to come to terms with, but that helped her to actually move on and implement the changes that she needed to, and engage with the health professionals involved in her care. So she felt more in control, she was feeling better in herself, re-engaging in her life and activities. She felt confident and continue working towards her goals by herself. She knew she could come back to us if she needed, and we agreed that discharge, and she felt ready to continue. So it's a case we're very proud of and we're happy to showcase. So now I'll pass on to my next colleague.
Thank you, Tanya. So it's Becky Clodfelter again from Therapy for You. It's a really inspiring clinical case there. I'm aware that a number of our colleagues who are joining us in the audience on MS Teams today will be working in the wider healthcare system. And I think what's really apparent from working with Tanya, Ed, other people on this call, that a whole team approach is needed. So not only within talking therapies, but very much with our, say, for example, North East Essex Diabetes, so the needs service, or those wider services, those healthcare teams. So it's really, really important. You know, I think we're showcasing today that we're prepared to work together and showcase. And I think that's so invaluable, but also in terms of that wider system working as well. And I think the experience has taught us, you know, over the past, and I think these LTC additional trainings have been in place from about kind of 2014, 15-ish, the top-up training, that actually it's really, really important that this is a whole team approach. So making sure that there are opportunities of co-working, co-sharing, but the wider system as well. So whether that's our commissioners or alliances, these kind of healthcare alliances, the communication is really key. I think one of the ways that we often do this really, what can be seen as quite difficult or hard work, is that sometimes you tap into the perhaps the people who are more psychologically minded or motivated, and then sometimes you get that kind of inspiring within. So it's really about collaborating, and relationships will always be key. And it doesn't just take me talking as a psychologist to say that relationships really are key to make sure that this is in place. So allowing time to integrate into pathways, co-locating is a lovely way of making sure that happens too. So sometimes physically just being present and allowing for that little bit of consultation, or just kind of breaking down those barriers. But again, things like supervision and allowing your physical healthcare colleagues to come along to those kind of clinics or drop-ins too. Again, it breaks down those barriers. So on to the next slide, please. So what we're doing today is really about promotion, but I can't say promotion enough. It's about being really proactive, collaborating, whether it's digital, in-person, social media, articles in the BABCP journals. There are lots of things that have been done at a local and a national level. Making sure that training is accessible across the services and across teams and across the wider system as well. Making things really easy. So sometimes people can perhaps perceive from other services that, oh, I'm being asked to do something extra or additional, or this will take time. So making sure that hopefully there's an understanding that actually if we get this right as holistic services, things will be in support of patients, in support of our wider teams, and actually referrals will be easy to make, and our time will be really well spent. So things like screening tools, there are very basic screening tools or diabetes distress scales, just making sure that colleagues are perhaps trained in those areas for screening. And then also making sure that we've got thick skin, but at the same time, being very willing and very compassionate and understanding and using all of those skills, but also be willing to train and be willing to kind of be tenacious and empathic, but resilient. Next slide, please. So what do we need to work on? It may seem like I'm repeating myself, and to some degree I am, but for really good reasons. It's about continuing to do these things over and over and over. So the pathways can be really robust, but if you've got people in place that you've built relationships with, but then of course COVID came along and people were then sent off to critical care wards to work, or other things such as 2P transfers, that people just leave their roles. It's really important that it goes beyond a relationship and there's strong pathways in place. So promotion, 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 I can't say it enough. Co-location and co-production, networking and service promotion. So taking every possible opportunity. Next slide, please. So lastly, there are things that as a wider system can be really helpful. So things like IT issues, if you've got a system that doesn't support the processes and support referrals, so you have to fill in everything separately, it just isn't going to work in terms of our diabetes specialists, for example, making referrals. So making sure you've got autofill systems, you've got shared systems where people can check notes. And that, in our recent experience, has really been found to be so beneficial. Making sure that we've got data, and we're all about data in these kind of psychological professions, and feeding back, being evidence-based, and we'll come on to that, or my colleague will come on to that in a moment. But it's about those systems being able to inform our practice. Training, as always, is really, really important, and making sure that we stay on top of that. And lastly, I can't emphasize this enough, but in terms of support within, but also support holistically, that of course this work can be really quite challenging and difficult, and compassion fatigue, the evidence shows that, the research shows it. Staff turnover, particularly in the past, has been so high, and it's really important that there's supervision, the support structures in place. On a personal level, I think that's one of the things that I've found most helpful in any of these services. It can be so challenging, but so very rewarding. And I'll pass you on to my colleague. So next slide, please.
Hello, yes, thank you. So in terms of the data and why you might want to refer for talking therapies, some recent research has come up with some helpful findings. So this slide in front of you here is showing that for people coming into talking therapy services, previously known as IAPT, there was by the end of treatment, there was a 45% drop in GP appointments. Next slide, please. So the diabetes distress scale, for those of you who don't know, is essentially a tool we use to monitor how well people are coping with diabetes. And the HbA1c is an average blood glucose reading. So what this slide here is showing us is that upon coming into talking therapies, the diabetes distress scale was correlated with a higher HbA1c reading. And by the end of treatment at talking therapies, the diabetes distress had reduced along with that HbA1c reading. Next slide, please. And the CSRI is a kind of questionnaire we use to assess the healthcare kind of appointments people are attending. So it could be GP appointments, it could be nurse appointments, etc. And what this slide in front of you is showing is that by the end of talking therapies treatment, there was a 26% drop in physical healthcare appointments. So it's showing that talking therapies can play a really, really important part in reducing stress on physical healthcare services. And there was also a 53% clinical recovery. So this was briefly touched upon earlier, but we use specific kind of measures around low mood and anxiety to measure what we call clinical recovery. So 53% of people here had also reached clinical recovery by the end of treatment. Next slide, please. And just on the slide here, we've got some general feedback that we've kind of collated from different services. So in the top center, you've got some feedback from a diabetes specialist nurse, which I think is really important to share because it shows the importance of joined up working and why it's beneficial if you're a practitioner sat here to refer into our services. So this nurse in particular was talking about the therapist being inspiring, about how much the patients took away, and generally been very good support. And then around that, we've also got lots of feedback from different clients in our services. So on the left-hand side, this person saying the service provided space to talk about the worries about their diabetes that they hadn't been able to. The person at the bottom here is saying something similar. The therapist took the time to listen to them and their problems, and they've even been back to their doctor to ask for more sessions. And lastly here, we've also got somebody 75 years of age who was feeling quite pessimistic or wasn't feeling particularly hopeful about the treatment, but actually it was a real eye-opener for them, and it's made them look at things differently and doing things that they weren't doing before. So some really nice feedback there that I think it was important to share. Next slide, please. So I'll hand you back over to my colleague now to continue. Thank you.
Hello everybody, so my name is Tammy Stone and I'm the long-term conditions lead for NHS Basildon and Brentwood Talking Therapies as well as West Essex Talking Therapies. So I'm going to kickstart us off today on our next part of the presentation in looking at how respiratory conditions have an impact on people's mental well-being and some information around respiratory conditions, which primarily we're focusing on chronic obstructive pulmonary disease, so COPD, as well as asthma, because I know someone said about long COVID, but hopefully we'll be able to answer some questions about that a little bit later. So thank you. Next slide. Okay, so just looking at the prevalence of respiratory difficulties then prior to the pandemic, so research gathered that 1 in 5 people in England were diagnosed with a respiratory problem, and it's the 3rd biggest cause of death. So we're talking big numbers here of people in England having a lung condition and actually it leading to death as well. Lung conditions are estimated to cost wider society around 9.9 billion each year. So there is quite an impact on our society financially as well. Thank you. Next slide. So just then thinking about, okay, there's all these people in England, a large number of people who have respiratory conditions. Now we can look at what kind of psychological difficulties people might experience. And researchers said that anxiety and low mood are around 3 times more prevalent among people with chronic lung conditions than in the general population. So they're at greater risk of experiencing those common mental health difficulties. In particular, so we've got people with chronic obstructive pulmonary disease and comorbid low mood and anxiety are more than 50% more likely to experience acute exacerbations of their COPD. So yeah, we're seeing that patients who have got anxiety and depression are more likely, if they have COPD, to experience those exacerbations and have an increased risk of hospital admission too. So use of A&E, those kind of things. And it's estimated that up to 51% of people, so it could be 1 in 2 of the people that we see with COPD, have clinically significant symptoms of depression and or anxiety disorders. So similarly, prevalence of panic disorder is markedly higher in patients who have COPD, and with up to 67% experiencing panic disorder. So big numbers here. So people that we are seeing with COPD, I suppose it's really key looking at this to look at how their emotional well-being is, because we know it's really common in this group of people. Thank you. Next slide. Okay, so we've talked a little bit around cognitive behavioural therapy and how it can help already, but what we know is, more generally, NICE guidance says that patients who have got a respiratory condition can benefit really well from having psychological therapy. In particular, CBT has been the most widely researched and has been proven to improve symptoms of someone's COPD by improving their mood first. So if we think about somebody who has got a respiratory condition like COPD, we know that symptoms can often include intense breathlessness, it could be chronic coughing, it could be excessive sputum production, it could also be fatigue as well. So there's lots of symptoms that a patient might experience in an exacerbation of their lung condition. What we know about CBT is that it's based on this theory that how we think and how we behave will then change how we feel. So often when we see patients come through to us in talking therapies, and you might notice this as well when you're with a patient or anybody with a lung condition, if you're experiencing those difficult symptoms from their lung condition, often people might have thoughts of things like this breathlessness is harmful. If I experience breathlessness, then something bad is going to happen to me. A lot of what if questions might come in, what if I pass out? What if I even die? So actually, exertion or physical activity might be seen as a harmful thing because that often raises our breathing rate. So how someone perceives that increased breathlessness might then lead to how they feel. And often if they have those kind of thoughts, we call them unhelpful thinking styles or anxiety provoking thoughts, they're likely to feel worried, anxious, stressed, on edge. And when they're having those kind of thoughts and emotions, they're likely to do things differently to try and minimize that effect or get rid of it completely. So it could be behaviors like not exercising, so making sure that they do very little in terms of physical activity, which in the short term can provide benefit because it reduces the breathing, but in the long term we know that then by not exercising, by not being physically active, often their condition might worsen. And then when they do exert themselves in some way, just maybe kind of walking a few steps, etc., or even up the stairs, and then they experience that breathing increase, all of those difficulties come back, that panic, that dread, that anxiety. So even though reducing physical activity in the short term feels like it's managing it, it doesn't get rid of that problem. So what we do in NHS Talking Therapies is we really help a patient to understand this cycle for them as an individual person. And we look at becoming more aware of their thoughts and behaviours so we can evaluate and kind of think about what is helpful in the short and long term and what might be unhelpful. And then together, collaboratively, we can look at how we can maybe bring in some more helpful thinking styles, more helpful behaviours, because if we target those things, then we're likely to feel a little bit better. If we're feeling a little bit better, we're more likely to kind of engage in more self-care behaviours to help manage our lung condition as well. So by targeting, and all our treatment, we adapt to the long-term condition, so the lung condition that we're we're helping that patient with, so we can make some adaptations to help a patient activate and do things that they want to do. For example, maybe pacing and learning about the boom and bust cycle are things that we might adapt treatment for. Thank you. Next slide. So I just wanted to talk through a case example. So this is a patient that came through to us, and this patient had chronic obstructive pulmonary disease, and their main difficulty was this difficulty breathing. And it was leading to panic attacks, stress, worry, and anxiety. And their main goal for support was to hopefully manage their mood, to then manage their breathing, and then hopefully live better with COPD, where it wasn't kind of taking control of their life. So anxiety was their main difficulty. And this patient in particular was around 58 years old, or was 58 years old, lady and employed part-time. Next slide, please. So just a little bit of an outline of that patient's journey. Brilliantly, the community COPD team referred this patient in, which we really encourage facilitated referrals to open up communication lines. We can share outcomes, we can share any difficulties, we can, if the patient has a question, we can easily reach the team if needed. So the COPD team did a bit of screening and asked that patient how they were feeling. That patient then consented to a referral into our service. And if we follow the top line first, the referral came in. We then did an initial conversation with the patient, which usually lasts kind of between 45 to 60 minutes, going through their main difficulties, how they're impacting their day-to-day life, and what they hope to achieve out of some support to make sure that NHS Talking Therapies is the best service for them. For this patient it was, and they chose, in our service we have a bespoke Living Well with Respiratory Conditions course, and all of the NHS Talking Therapies will have some kind of course or group work for long-term conditions, and this person opted for this option of treatment, and then attended the 6 sessions and felt better afterwards, and I'll go into that in a bit more detail in a second. But yeah, like I said, the bottom line there just basically says that because that referral came in from the COPD team, we are able to liaise with them with the patient's consent, and then we can have that really holistic approach to their care. Thank you. Next slide. So as we've said earlier, we do routine outcome monitoring via questionnaires every single session, or we try to anyway. Sometimes the patients might miss them, but yeah, in the groups we try and collect them every session. The left-hand graph is assessing symptoms of depression and low mood, and you can see that at the start in the assessment, this patient's symptoms of depression were in the severe range, and then by the end of the 6 sessions of the Living Well with Respiratory Conditions course, they came down to a 5 out of 27. So that's the lowest end of that mild symptoms of depression. So a huge significant improvement in low mood. On the right-hand side, you can see that this is a graph representing their anxiety symptoms, also going from severe range of anxiety down into that more mild range anxiety throughout the course and by the end of it. So again, a lot of improvement on anxiety levels. Next slide, please. And the work and social adjustment scale, like we said earlier, is assessing daily function. So what is the impact of their mood and their lung condition on their daily lives? And you can see that again there was a significant reduction, so improvement of how they were functioning daily by the end of the course. Thank you. Next slide. And this was just some feedback from the patient, which I'll read out. So yeah, this person said that it was an amazing course on every level, and it was very good and easy to listen to, and things were explained well. What's really key with this feedback is this person said that their ego kept refusing the support, and you might see this or experience this before, where someone might mention to someone about emotional well-being support and they kind of shut it down straight away, and that's okay because we're planting the seed. We know that symptoms of low mood would be, how can they help me? And for this person, they quoted, "There is nothing they can teach me." But they said that actually their practitioner from the COPD team talked to them about it a few times, so kind of planted the seed and then checked in regularly as part of their care. And then this person did come around to the idea of giving it a go, and they spoke very highly about it, been so pleased. We also have guest speakers come onto our course to help with that integrated care. So we have nurses, physios, practitioners that come in. But this person said that they couldn't fault the support, advice, empathy, caring and encouragement, 100% success rate for them. And they took away a lot of strategies such as understanding the vicious cycle, that CBT cycle, gaining coping mechanisms such as pacing and breaking down the housework, and felt that her COPD symptoms do not happen so badly and she doesn't go into complete panic anymore. So yeah, hopefully a good case study to go through. And now I think I'll pass over to my colleague Josie.
Hello, yes, I'm Josie. I'm the long-term conditions lead from Inclusion Therapies, so an NHS Talking Therapies service. And what we're going to show you in just a second is a video from my colleague Irene. So she's from the NELT, that's North East London Foundation Trust. She's from the respiratory team there, and she's just going to talk to us a little bit about the benefits of integrated working with an NHS Talking Therapy service.
My name's Irene. I work for NELF's integrated respiratory team. As part of my role as an assistant practitioner, I work closely with Inclusion, linking together predominantly pulmonary rehab and Inclusion, but also the wider respiratory service, so home oxygen, COPD, virtual walls, that kind of thing, all the remits that we cover. I've been working with Inclusion now for a couple of years. Historically, we used to have Inclusion come down to our monthly support group that we used to run for respiratory patients pre-pandemic. We used to find that actually patients that could see an actual person from this service and discuss with them what they have to offer, their referral criteria, all those bits and pieces, were much likely to take up the offer of a referral. I think because it put a face to the service, it kind of broke down some of the barriers of not knowing what to expect from a service. It broke down the kind of taboo of talking about mental health problems and struggling. We find in pulmonary rehab that predominantly a lot of our patients, because of the age groups they are reluctant to accept and discuss anything to do with mental health and struggling. And it's only now, I'd say probably in the last year or so, that a lot of more patients are receptive to talking about mental health problems alongside living with a long-term condition. I think working closely with Inclusion works really well, because for patients coming into us from Inclusion, they're already motivated to attend the courses there and discuss, you know, their condition, their feelings, how they're coping with it. So they're then, we find, quite motivated to come and join pulmonary rehab, and they're already quite open to the concept of, you know, trying new things to manage their condition. One of our biggest barriers in pulmonary rehab is getting patients to come in that are breathless and then asking them to push themselves and get exercise. So this really helps kind of break that barrier down for us. And on the flip side, I know discussing with patients week in, week out, you know, all about our anxieties and depressions around managing our long-term conditions, and also the importance of your mental well-being as well as your physical, and how the two go hand in hand, means that when we get towards the end of our sessions and someone from Inclusion comes to give us a guest talk, patients are a lot more receptive to that idea, as opposed to just being told, started, we've already built that rapport with patients, there's that trust there, and they are definitely more willing to come to us and say, yeah, please do that referral for me, I'd like to, you know, carry on learning how to manage this respiratory condition. And again, because patients are already engaged in pulmonary rehab, they're coming twice a week to see us, they're spending 2 hours with us a week, they are quite engaged and quite motivated to go and give that course with inclusion a go. They're probably more open-minded, I would say, because of the conversations that we've had prior to that. So yeah, I feel like generally it's a really good working relationship between the two services, and I definitely feel it's breaking down that taboo for a lot of patients of, you know, not talking about mental health, not talking about struggling, and it seems to be working really well for us. There seems to have been a big shift post-pandemic about, you know, talking about well-being and mental well-being and how this works really closely with physical health. And we're very big on, we say to patients, you know, we can manage the physical side of your condition, but you know, we need your mental well-being to be there as part of that, and for you to feel the benefit of it, you know.
I think I'm going to pass over to my colleague James.
Okay. Hello, everyone, and thank you very much, Josie. So, yeah, real pleasure to be here presenting as part of the team today. So I'll just quickly introduce myself. So my name is James Sparks. I am a senior clinician at the Mid-Essex NHS Talking Therapies service, and I lead on the long-term conditions work that we do. So I'm going to be talking a bit more about what is happening in the east of England for those with respiratory conditions in NHS Talking Therapies services. I'm very much echoing the messages that and excellent work that Tammy and Irene have already highlighted with the respiratory patients. So as you can see on this slide, we have a visual representation of the pathway that's been developed in Mid-Essex between our Mid-Essex Talking Therapy service and the local respiratory services. So the main aim of developing a referral pathway between physical health services and NHS Talking Therapies is to help improve the access of physical health patients to evidence-based talking therapies, which we know has already been stated, has a very positive impact on a range of factors, including, of course, the patient's physical health outcomes and their mental health outcomes. So on this pathway, as you can see, it all starts on the far left, where we have the pathway starts with a respiratory patient entering a respiratory service. At this stage, a real priority is screening for mental health. So any patients who do present with a mental health problem can access talking therapies as soon as possible. So as you can see in the yellow box there in the middle, one of the main ways that we try to support physical health colleagues with this aim is by carrying out regular training delivered to respiratory staff on several things. Firstly, how to recognise and screen for mental health, the language used when discussing referral, the benefits of accessing talking therapies, and about our talking therapies service and how to refer. And we have really found that a lot of the success of the referral pathway really comes from this training, so it's really worth doing. So as you can then see on this slide in the middle green section, if mental health is identified and a client is suitable for talking therapies, then we really encourage physical health staff to make a referral to us. We have found that using a fast track professionals referral form that can be quickly and easily emailed across to our team was essential. And it made it much more likely that respiratory colleagues would be able to facilitate the referral themselves. So at Mid-Essex, respiratory staff have actually embedded our referral form into their computer systems, so it auto-fills all the patient's details and it can then be emailed straight to our talking therapy service. And that was a real advantage, makes it a lot quicker and easier for physical health staff. As you can then see, so the large orange box at the top left, before people access talking therapies, we also deliver mental health workshops in the community to a range of different respiratory groups, which again helps enhance the awareness and access to talking therapies. And at the bottom left in the red, you can see that we run co-located joint clinics with respiratory physical health staff and also attend ward rounds helping to screen for mental health needs. This also helps to promote talking therapy services to patients, but also to patients' families, and of course also to respiratory staff who also may benefit from support. So all of this co-located working allows us to get to know respiratory staff a lot better, and overall improves awareness of the pathway, and also supports respiratory staff in identifying mental health in their own patients. Further along, the central line in green shows that once we receive a referral, the majority of patients are then assessed by our specific respiratory pathway workers, which improves the quality of the assessments, and if necessary, joint assessments have taken place with physical health staff as well. If patients are suitable for treatment, they would then be treated by LTC trained workers, which again improves the treatment of these respiratory patients. Our talking therapies workers also periodically receive training on respiratory conditions from respiratory physical health staff, which also helps our staff be more aware of the challenges respiratory patients face. Okay, next slide, please. So, we know that it can be very difficult discussing someone's mental health with them, especially if the topic that we used isn't very familiar with them or they don't recognise. So here's a few tips on sort of discussing mental health and how to encourage and support a referral. So firstly, using clear language is very, very helpful. So clear language like, you know, have you been feeling low or anxious, or have you found that you might be worrying more than normal? It's really important to try to stay open, but also normalize mental health and reduce any stigma. And saying things like, you know, we know a lot of people living with long-term health conditions can have a real impact on their well-being. What we want is a real sort of gentle suggestion, a really encouraging but positive approach that normalizes the whole referral process, not just mental health, but actually normalizing the referral process too. So again, saying things like it's standard procedure, you know, if we pick up this, then we usually do recommend, you know, they might be able to offer some support, so no harm in trying. But what we also need to do is we need to balance up this sort of suggestive, encouraging approach with it still always being collaborative. So, you know, what we don't want to do is try to be too pushy or anything like that, because otherwise what we then have found is if that happens, then clients or patients do refer, but then actually they don't engage very well because, you know, they weren't really included in the discussion, and they may not have actually wanted to refer. So it's of course always important to be collaborative. And then on the bottom left, the language used is really important too. We want to try to avoid any words and labels with any stigmas attached to them, which might be something like saying, you know, you're depressed or mental illness. And instead, actually, what we want to try to do is use the patient's own language. And, you know, that is far more likely to be received well if we're reflecting it in their own words. And then lastly, on the bottom right, hugely important, is highlighting the potential benefits of a referral to us, because a patient, of course, may not understand that. So saying things like, you know, it's easy, there's lots of treatment options. All I do is email this short form across and they'll contact you, but also reminding them that it is confidential, as they, of course, understandably may be anxious about that. Okay, and next slide, please. So we've already discussed that you know, it can be very difficult for some patients to recognise when they're experiencing mental health problems, or they may not want to talk about it, or they may not be aware of the benefits of a referral to mental health services. And of course, as I've said, there is a stigma attached to mental health at times. So for this reason, physical health staff play a really vital role in helping to overcoming all of these initial obstacles and promote access to talking therapies. And without these efforts, actually, you know, the mental health needs of many patients may go unmet. So it's really important. Now, the need for good links and clear lines of communication between local talking therapy services and physical health colleagues is essential. This can really make or break a referral pathway. So we often find at Mid-Essex that just by having a 4 or 6 weekly catch up with physical health colleagues, this really encourages more ideas, more developments to the pathway, ensuring consistent improvements, and it really prevents stagnation and neglect of the pathway. It also just provides valuable opportunity to ask each other questions and learn more. So as I touched on earlier, training delivered to physical health staff from local NHS Talking Therapies services about what talking therapy services can offer and the benefits of accessing talking therapies is a necessity. And this aids the entire process of identifying mental health and helping patients access talking therapies services. Training delivered digitally can be recorded and then added to the induction of physical health staff. And this is something we've done at Mid-Essex. And this really helps to combat staff rotation and throughput. Ensuring that mental health screening tools are quick and easy to use is really important. That's something that physical health staff have told us, especially with the pre-existing demands already placed on those physical health staff. As can be seen on the right-hand side of this slide, the use of the PHQ and GAD2 are the screening tools we often recommend physical health staff use. In addition to this, the use of short, fast-track referral forms for professionals to use encourages referrals by making the process as easy and quick as possible. Of course, an added benefit to this is that if their professionals are referring them directly to us, it means that we can then monitor and audit the pathway and keep track of the figures. So we very much encourage professionals to refer their patients directly to our talking therapy service, as we have found that asking patients to self-refer actually creates a barrier to access due to the nature of mental health. So, for example, if you ask a client to self-refer because of the nature of depression, anxiety, so for clients may be experiencing low motivation, low energy, poor concentration, which means that they often don't go through with the referral. So we really encourage that professional's referral. Okay, next slide, please. Right, so what to look out for when identifying mental health problems. So these are some tips for what to look out for. So finding if a patient is finding it difficult to follow medical advice or not doing their exercises, reductions in activity levels and social contact can be a sign. Changes in behavior is common, not being able to keep up with hobbies and exercises that they used to do, difficulty sleeping. Next slide, please. Thank you. And being quiet or having less energy or motivation than normal, weight loss or weight gain, loss of appetite or overeating, an increase in the use of recreational drugs and alcohol, or also changes being more angry or irritable than usual. And another thing for physical health staff to be really aware of is that it's incredibly useful sometimes to also ask family members if they've noticed any of these changes, because obviously patients themselves sometimes don't recognize or may not want to talk about it or this. So actually speaking to family members is also incredibly useful. Next slide. Okay. So we've got some, I think was really important feedback here from people who have used the service. So because there's quite a lot on here, I won't read through these all myself, but what I'll just do is give you sort of 30 seconds to read these this feedback out, and then we'll move on to the next session. So thank you very much for listening to me.
Thank you. And we will make the slides available after the event, probably in a week or so, maybe a little bit longer. So just coming back to me now for a summary. So we hope that we've shown you about the reciprocal relationship between physical health and common mental health problems, and the adverse impact of anxiety and depression on someone's ability to manage their physical health. We've talked about how psychological interventions can help, and the help that and about how to spot people who would benefit from psychological interventions. And we've had a think about how physical health colleagues can discuss referrals. And we've shared some of our outcomes and patient feedback. Could we have the next slide, please? Okay, we would really welcome your comments and questions in the chat. Do put them in there, and we've got about 7 or 8 minutes to think about some of them. Can I invite our presenters to come back onto the screen, and if we remove the slides? I think when I was listening, one of the things that I heard was, just how important it is working together with physical health colleagues and integrating those services. And I just wondered whether anybody wanted to say anything about what in their experience makes the most difference to the patients that you've come across.
Maggie, I think one of the things that makes a difference is I think it's so difficult for these physical health patients anyway, and for staff. I think there's so much confusion. There's often so much confusing and so much going on. I think just having physical health staff and talking therapies, working closer together and just making everything a lot clearer and more understood just makes such a big difference, I think. And we've, as can be seen in a lot of the feedback we've tried to give in today's presentation, it really does. I mean, it's difficult to quantify the impact that it has, but it really does have a huge meaningful impact, and it really does improve their quality of life. It's difficult to quantify that, but one thing we continually hear is that it does really have a huge effort. But of course, it's a huge mutual benefit, because it increases the patient's quality of life, but it also increases their physical health outcomes. So it just really benefits everyone.
And I guess we heard from Irene how much difference it makes to the work that's being done in physical health as well, that they're trying to do with people who are using services.
And one of the things I've noticed is that good communication between services is really helpful. One of the things that tends to really annoy patients is when we don't communicate well. So good communication really does help.
Yes, and I know one of the things we've talked about in our group is how important it is for people who use services not to feel as if they're being passed around, understandably. So having that sense of joined up working is so important, isn't it? One of the questions that I saw in the chat was one about diabulimia, and I wondered if anyone wanted to say what we do when we have referrals for people whose diabetic control, so their use of insulin, interacts with their eating and weight. Have we had referrals like that into our service?
I'm not sure I have since I've been with the service, but I think as with any of these cases, if you're ever unsure to refer in, there's nothing wrong. We can always do an assessment and we can always have a think about what the best treatment options would be for that person. I'm just trying to think back, but yeah, certainly not since I've started. I'm quite new to the role, I think, but I always encourage referrals into the service. Absolutely.
I think, sorry, it's Katie. I'm from the Therapy for You NHS Talking Therapies service. I think I have come across a couple of cases like that, and in those situations, I've always encouraged people to liaise directly with the diabetes nurses. So that could be at the time of assessment, but it could also be when working with someone that has diabetes, and obviously just to make sure that their safety is first and foremost, really, and just to make sure that they've got any, if there's the diabetes programs, that they just to check that they have done those, and also just making sure that the diabetes nurses can link up with the patients as well. So it may not be that we cannot work with them at that time. It may also be that we can, but also it's just making sure that everyone, the diabetes colleagues, are involved as well, and just doing like a holistic joined up care in that way.
Thank you, Katie, and thank you, Ed. I saw that there were a couple of questions about long COVID, and I know that a number of you are involved with the long COVID clinics that are happening across the region. Did anybody have any comments about long COVID to share with us?
I think in terms of talking therapies and how we can support people with long COVID, we would look at their symptoms. So again, treating everybody individually and looking at how their long COVID affects that person. And then likewise, then how do their symptoms of long COVID affect their mood and how they're feeling, what they're doing, how they're thinking. And then we can still work within our scope of practice to support people with long COVID who have got anxiety and or low mood as a result. We know that, again, there's breathlessness symptoms, there's fatigue and tiredness, which, yeah, definitely can affect someone's thought processes and behaviours. So there's a lot of work we can do, and we work closely with long COVID teams as well. So that's where we integrate and make sure that a patient is supported for all their needs, because often there might be some cognitive difficulties in long COVID. So there is support there as well from long COVID teams. So yeah, we can still definitely work with people with long COVID.
Thanks, Tammy. One of the questions that I can see, or one of the comments in the chat, is about having recruited somebody to the specialist diabetes psychology team. And there's a kind of a question about when should people come to us in NHS Talking Therapies versus when should they go to more specialist colleagues. And I just wondered what our experiences are of that.
Just wanted to mention, I used to work as a health advisor in my previous job, and we had work in inner city area. Quite a lot of work and resources had gone to help diabetic patients, and very recently I was also involved again with UWE because they have received from NHIR some funding to make new AI, artificial intelligence, like we have Alexa, they call it Romi, a new technology that would have information to help people who have type 2 diabetes. So they were doing lots of group discussions and talking to people so they can get feedback from type 2 diabetic patients what to include in Romi. So I wonder whether universities or research departments are talking to each other to do this collaboration work. It is not yet ready. They are just in the initial stages, but they have received quite a lot of money to put efforts into this project. And I can't remember ROMI was the full form, what they call it. But it is a kind of app which will be downloaded on the phone to get the information, and they have some plans which will be directly linked into the GP services. So I just thought to mention this. So there is collaboration in between, you know, improvement and health services as well.
Thank you. It's always good to hear about new innovations that are coming along. I'm aware of the time, and I think we probably have to finish. I don't know if anyone is able to say anything quickly about whether people should stay with specialist services and when they should come to us.
I think, Maggie, it's useful in those instances to be quite aware of the specific commissioning requirements. So, for example, NHS Talking Therapies inclusion and exclusion criteria. And for example, in Mid-Essex, when deciding if a client might benefit from more specialist input or actually whether NHS Talking Therapies would be most appropriate, is having a think about what their main presentation is. So is it a common mental health problem, or is it something more severe, or, you know, like a serious mental illness? But also, you know, NHS Talking Therapies primarily tend to offer brief psychological interventions. So again, if looking at a patient's needs, if we think actually a brief intervention, they may need something more significant, or they may need some more specialist or longer term support, then again, it may not be suitable for an NHS Talking Therapy service. So it's often just sort of having a think about our inclusion exclusion criteria, and if their needs are actually quite complex or a lot of sort of comorbidities, and then actually they may benefit from some specialist input. But most of us all tend to liaise quite well with the specialist sort of providers too. So often it's having a bit of a discussion or an MDT approach and deciding then where it might sit, and often trial and error as well.
Thank you, James. And what I'm hearing is the importance of actually just having conversations about it and getting in touch and linking in. So thank you very much. Could we bring the slides back, please, just to finish off? So if we could move on to the next slide. Okay, so we are going to put a link in the chat to the feedback form, and we would really appreciate your feedback. The feedback that we get really makes a difference to how we do things going forward. So please do tell us, share with us. That's great. It really doesn't have very many questions. It shouldn't take you long, but it will make a huge difference. Thank you. And if we could have the next slide. So here is some information about the rest of our East of England PPN week activities that are happening. So we have tomorrow the counselling psychology, showcasing the role with a particular focus on the East of England. And on Thursday, we'll be celebrating our East of England clinical associates in psychology. So this is a really new role and just developing in the region. And we really want to celebrate the CAPs that we have. So that's great. Do we have another slide? Thank you. Thank you to all of our fantastic presenters who have worked so hard on bringing this together and really shared all of their expertise. Thank you so much, presenters. Really great to work with you. Thank you also to our brilliant PPN team of assistant psychologists and Hina, our trainee clinical psychologist, people who've really worked so hard to bring this together. Thank you very much. And thank you to you, for our audience, for contributing so fully and for your comments. Thank you very much indeed. And if you asked a question, I'm sorry that we didn't get around to answering it. Thank you very much, everybody.
Thank you to you too, Maggie.
It's a pleasure. Thank you. We'll close here.